Welcome to the NEI podcast. In today's episode, we're coming to you from the 2023 NEI Congress in Colorado Springs, Colorado. We'll be hearing from one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations.
Hello, my name is Dr. Robyn Thom, and I will be answering your questions about my presentation, The Full Picture, Managing Autism Spectrum Disorder and its Frequent Psychiatric Comorbidities. So the first question we have is, who should be diagnosing autism, and is it normal to diagnose autism in adults? Well, that's a really great multifaceted question. So actually, there are a number of different healthcare providers with a variety of training backgrounds who may be qualified to diagnose autism. And I think there actually can be quite a bit of variability regionally across the country. Some providers who have experience making autism diagnoses include child and adolescent psychiatrists, psychologists with expertise in autism, developmental and behavioral pediatrics, as well as neurologists. I actually think that it's less the title of the person, but really more whether they've had specialized training in the autism diagnosis. The second part of that question was, is it normal to diagnose autism in adults? And unfortunately, my answer to that is absolutely. Our knowledge of autism has increased so much, especially in terms of what autism looks like in people who have higher cognitive ability and language ability in the last 20 to 30 years. So people who are now 20, 30, 40 and older than that, really when they were little, when they were children, which is when we would hope most people would be diagnosed, we knew so little about the condition. So I think in 2023, we're really still in a position where we're playing catch up. And there are probably many adults out there who have autism spectrum disorder who did not receive diagnoses as children. Next question. Can you please comment on hallucinations or psychosis in ASD? Is it a part of ASD, or should one screen separately for a psychotic disorder? Well, just to review, the core symptoms of autism spectrum disorder are social and communication impairment. That's the first bucket. And the second bucket is restricted and repetitive patterns of behavior. Hallucinations and psychosis are not part of the core diagnostic criteria for autism. That being said, people with autism definitely are not immune to experiencing psychotic symptoms or indeed full-blown psychotic disorders such as schizophrenia. The literature is still a little bit mixed, so I think the jury is still out, but it is possible that people with autism may be at a slightly increased risk of developing a psychotic disorder. Remember, schizophrenia is a rare condition. It's something like 1 in 100 people. So even a slight increase in the risk of schizophrenia in autism would mean, even if you doubled that risk, it's still very, very rare at 2%. The next question is, are there ASD subtypes or subgroups for which certain medications are more effective in managing target symptoms? What a great question. I love this. This is really thinking about how can we move towards personalized medicine for patients with autism spectrum disorder, which is absolutely critical because the spectrum is so broad. We hear time and time again that if you've met one person with autism, you've met one person with autism, which is true. But the spectrum is so broad now. We see people who have no language ability and really no interest in social contact or connection, to people who have normal, fluent speech, who so deeply desire social connections, but really lack those kind of automatic or innate core social skills. So it makes so much sense. And I really think that this is the direction that our field is headed in, looking for how can we subgroup or subclassify autism for better precision medicine. At this point, there is a lot of research looking for different subtypes or subgroups of autism spectrum disorder. For example, our group has done some work looking at whether there may be an immune-mediated subtype of autism, for example. And other groups have looked at different ways of classifying autism, but at this point, there really is not any clear and consistent evidence that there are useful subgroups for selecting medications. That being said, if we kind of just go back to basics and we divide things by clinical characteristics like age, there is data to show that the younger the patient, probably the more likely they are to get activated by a selective serotonin reuptake inhibitor. So you may have more success with SSRIs in adults. And then this is more based on clinical experience and anecdote than data. But I find frequently in my clinical practice that patients who have more severe autism, so like level 3 autism with accompanying intellectual disability and language impairment, this subgroup of patients seems to be at higher risk for experiencing behavioral activation with an SSRIs than the more mildly affected patients, at least in my practice. So the next question is, are there any non-pharmacological interventions that can complement medication treatment for ASD target symptoms, and how can they be integrated into a comprehensive care plan? This is a wonderful question, and I'm so glad that this one was posed because really the care of a patient with autism spectrum disorder is dependent on having a multidisciplinary team. The use of psychopharmacology is an important piece of treatment for many patients, but really should not be the only treatment that a patient is getting. Just like with medications, where there's a wide variety of medications to choose from, the same is true for non-pharmacologic interventions. So really, I think each patient needs to be assessed on an individual basis to determine which interventions are going to be the most high yield, right? Patients really do not have time or resources for everybody to get speech therapy, applied behavioral analysis, physical therapy, occupational therapy, feeding therapy, cognitive behavioral therapy. Nobody can do it all, at least not all at once. But it's absolutely critical that each patient is evaluated individually and then periodically from time to time, right? Because as people make developmental progress and grow up and encounter new challenges with different developmental stages, different types of non-pharmacologic interventions may rise to being more important than they were previously. Is fluvoxamine effective for the obsessive symptoms in autism spectrum disorder? Well, I'm so glad that this question was posed because it gives me the opportunity to talk a little bit about obsessions in autism spectrum disorder. So one of the core symptoms of autism spectrum disorder is intense, restricted, and fixated interests. Colloquially, those are kind of just referred to as special interests by many of my patients. That's where they have a very deep and abiding and kind of superhuman knowledge about a topic that they're very interested in. Historically, we thought that the topics were a little bit odd or idiosyncratic, things like trains or fossils or like kind of non-human things like machine. But more and more, especially as we've learned more about the presentation of autism in girls and women, in particular, we're learning that the special interest can be quite age and culturally appropriate. So, for example, I've been hearing a lot, I have to say, in the last year or two about special interests in Taylor Swift. So colloquially, patients and families will say, my loved one with autism is obsessed with Taylor Swift, or they have OCD because they always want to have things lined up just so. Those are not OCD. Those are core repetitive behaviors associated with autism. And SSRIs really are not effective for those symptoms. However, people with autism are not immune from experiencing true OCD, on top of their autism spectrum diagnosis. And OCD and autism looks very similar to how OCD looks in a person without autism. So you're really looking for those classic obsessions and compulsions you would see in a person without autism. So, for example, obsessive thoughts about germs, which are accompanied by compulsions related to the germs, like washing or cleaning cleaning compulsively. You may have patients who have obsessive thoughts, intrusive thoughts about harm coming to them or their loved one or violent images. And they may need to do a mental ritual like counting or praying repeatedly so that their loved one doesn't get hurt. For true OCD, that is comorbid with autism spectrum disorder, we generally do use standard treatments, including selective serotonin reuptake inhibitors such as fluvoxamine. Is irritability and severe tantrums in autism related to intermittent explosive disorder? This is a really good and complex question about diagnosis in autism. One thing that we have to remember when we're thinking about this is there are 2 FDA-approved medications for irritability and autism, which is a little bit unusual because usually the FDA approves medications for a disorder or a diagnosis rather than a symptom domain. But really, the context of the word irritability for the FDA approval of risperidone and aripiprazole was more for chronic, nonspecific irritability and severe tantrums for which there's no clear etiology. And it kind of occurs in a chronic, smoldering way, which is unlike intermittent explosive disorder where there are periods of lulls, the child's okay, and then suddenly you get these big outbursts. Can you please speak to the use of low-dose naltrexone in ASD? Well, naltrexone has a number of different uses in psychopharmacology. Probably most commonly, outside of the ASD context, we think about it in the addictions realm. In ASD specifically, there is some data to suggest that naltrexone can be helpful for self-injurious behaviors, probably by modifying the opioid regulation system. Do you have experience or an opinion about using amantadine or riluzole in autism for mood, lability, and or irritability? There's really no data, or high-quality data at least, to suggest that either of these medications are helpful for mood, lability, or irritability in patients with autism. And because of that, and considering that we have many other medication options, either with stronger evidence or even FDA-approved medications, these are not medications that I commonly use in my practice for these indications. Can you share insights into the role of families, caregivers, and educational institutions in supporting individuals with autism and managing their comorbid psychiatric conditions in line with the presentation's learning objectives? So one of the wonderful things about working with individuals with autism spectrum disorder is that as a psychiatrist, I never feel like I am stranded on an island with just me and the patient. More often than not, especially in patients who are still in the school age range, there's a large supportive team helping them meet their goals, including, of course, family members, caregivers, and schools. And one of the silver linings about the pandemic and doing a lot more telehealth is it makes it so much easier to have multidisciplinary visits where we are not just seeing a kid and their mom in the room, but we're also having their occupational therapist Zoom in and their special education teacher, and getting these collateral reports from multiple people in the patient's life about what the most concerning symptoms are, how they're responding to medications, if there's concerns for side effects, and really getting alignment on treatment goals. What is most important to work on first? What are our treatment expectations? No medication treats everything, so making sure that the whole team is on the same page about if this medicine works really well, this is what we would see. So great question, incredibly important to bring in the whole multidisciplinary team whenever possible. Can magnesium glycinate assist with sleep in ASD? There are no high-quality trials assessing the role of magnesium for sleep in autism.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.